Please feel free to put your name in the chat. All right, so good morning, everybody. I'm Diane Schrody. I'm with the Division of Drug, yeah, I'm sorry, Division of Program Support and I am so sorry, Program Support and Quality Improvement here at the Department of Drug and Alcohol Programs. I'm running everything into one name this morning, so I apologize for that. Before we get started, I just want to make sure that everyone is aware of the wiretap law in Pennsylvania. So in accordance with the Wiretap Act, it is against the law in Pennsylvania to record oral conversations without the permission of individuals involved in most circumstances. So this session is being recorded for training and or recording purposes. By participating in this session, you are consenting to the recording, retention, and use of this session. At any time, if you have a question or comment, please feel free to place that in the chat, and we will respond to that and get back to you as soon as possible. If you would like to ask your question or to comment verbally, please note that by doing so, you are consenting to the recording, retention, and use of your statements recorded as part of this session. For our presentation, we will not be taking questions. We will take them from the chat, and then if we have time, we would answer them. Otherwise, we do put out a Q&A at the end of the presentation in the upcoming days. So if you are not comfortable with this session being recorded, please exit this call if you do not want to be recorded. You will be able to review the video in its entirety on the DDAP website following the event. Okay, so if everybody is all set, we're ready to get started. So again, my name is Diane Schrody. I'm with the Division of Program Support and Quality Improvement here at DDAP. And today we have some special guests with us from our sister agency, the Pennsylvania Department of State, who are going to talk with us about voting in Pennsylvania. This is really important, especially for our residential treatment providers, in case you have anyone who would be interested in voting and they are not going to be located in their county or their state. So with us today is Mike McDonald, Director of Policy, and Danny Bendeski, Special Assistant for Strategic Initiatives. And they're here from the Department of State. So I'm going to turn it over to you, Mike and Danny.
Thank you so much, Diane. As Diane said, I'm Mike. I'm the Director of Policy at the Pennsylvania Department of State. Among other things, the department is responsible for administering and overseeing elections in Pennsylvania. So we have been working hard this year, as we always do, to make sure that Pennsylvania is prepared for the election this November, that Pennsylvanians know their rights and responsibilities, and that every eligible voter is able to cast a ballot and have it count. We wanted to take some time to speak with you this morning. We really are grateful to Diane and the whole team for giving us a few minutes. We know that you all may be encountering individuals, residents, people who come in seeking treatment, or find themselves in all different circumstances. As Diane said, they may be outside their county of residence or where they're registered. They may have emergent situations that arise close to the election. And I think you all will be in a unique and important position to support these individuals and make sure they understand how they can go about participating in the election, even if they're not, in their home or dealing with unexpected circumstances. So we wanted to just give you a rundown of some of the important information about the election, some important information about ways of supporting people with voting, and just directing you to some resources the department has available so that if questions come up between now and November, you are nowhere to look for information to help the people you are serving. So first, one of the key ways that we encourage people to vote in Pennsylvania, or that at least is available for people to vote, is no excuse mail-in voting. This mail-in voting has been around for a very long time in Pennsylvania, for well over 100 years. It wasn't until 2019 the General Assembly passed a law that introduced no excuse mail-in balloting to the state, which means that any eligible voter can vote by mail for no reason or any reason. So you don't have to show up at the polls on election day. It's very convenient. It is very easy and it is very secure. The deadline to apply for a mail ballot is October 29th, 5 p.m. on October 29th. You could apply by visiting your county election office, by sending in a paper form. You could also apply online at our Department of State website, which obviously is quick and convenient. Um, excuse me. When you fill out your mail ballot, it's very important that you follow all of the instructions carefully. You have to sign your name. You have to put the date on the day on which you sign it. And you also have to seal your ballot inside what we call the inner secrecy envelope or the yellow security envelope, which will look like the image you see on your screen. It'll say official election ballot on it. You have to seal your completed ballot in that envelope and then put that sealed envelope in the outer envelope with the voter's declaration on it, which is the image on the left. Excuse me, again, you will have to sign and date it. And it's important to put the date on which you sign it, which maybe for some people goes without saying, but it's could be surprising how many ballots end up being canceled or subject to scrutiny because the voter inadvertently puts their birth date or they'll write the date of the election or something else. So it's really important that you communicate that voters have to put the date on which they sign the ballot. You could go to the next slide. There are lots of ways under state and federal law to assist voters who may need some support while voting. Voters with disabilities are entitled under federal law, the ADA and the Civil Rights Act, to seek help with any aspect of the voting process. They can designate an agent. We call it a designated agent. They can designate an individual to assist them with voting. The Department of State makes a form available online. It looks like that image on your screen that the voter and designated agent complete together. And then the designated agent can help that voter with whatever they need help with. They can retrieve balloting materials for them from the election office. They could take the ballot back, drop it off at a drop box, or take it to the election office. They could assist the voter with filling out the ballot, whatever the voter needs help with. If they have a qualifying disability, they can designate an individual to assist. And we just actually updated these materials to align with some new federal guidance that came out from the U.S. Department of Justice that made clear that a voter can designate any individual to assist them, no matter how many other voters that individual may have assisted. So a designated agent can be a designated agent for multiple voters. For instance, if there are multiple voters living together in a congregate care setting, in a residential facility of another kind, a designated agent can assist however many of them choose to ask that agent for help. And again, it's important. We encourage people to fill out this form. Keep a copy with them. A voter, when they fill out this designated agent form, can take a picture of the form with their iPhone, and that's fine. Just keep the photograph with them. And the agent should have the original form with them whenever they're conducting business on behalf of the voter. If they're taking a ballot back to the election office, for instance, they should have the form ready just to be able to show and verify that they are duly assisting another voter. We have a lot of other sort of resources available to make the voting process more accessible. Every polling place, I should say, is required to have at least one accessible voting machine, meaning a machine that would have features on it that could help voters who maybe are hard of sight or need other kind of assistance. Voters can get assistance at the polling place by having somebody talk to the judge of elections or another poll worker there. The judge of elections is the official who's in charge of every polling place, and they could authorize a voter to get assistance with using a voting machine, for instance. And we also have certain accessible ballots available for individuals with certain kinds of disabilities. Again, for instance, if somebody is blind or visually impaired, we have special ballots that are available that they can use that'll help walk them through the process of filling out the ballot, and they can complete it electronically so that they don't have to travel anywhere to do it. And we have a lot more information about this on these links on the screen: vote.pa.gov/voting systems and vote.pa.gov/accessible voting has all these resources available. A really important thing to know, especially if you're dealing with individuals who may be encountering exigent circumstances, like I previewed at the beginning, is that Pennsylvania allows voters to request and cast what's called an emergency absentee ballot. So the deadline for applying for a regular mail ballot is 5 p.m. on October 29th, starting at 5:01 p.m. up until the close of the polls on Election Day, 8 p.m. on November 5th. Voters can request what's called an emergency absentee ballot. And our applications and forms for this are available online. Basically is saying that there was some unexpected circumstance came up that will be preventing you from voting in person when you otherwise may have planned to. A great sort of common example is that an expectant mother goes into labor a couple days before the election. She had planned to vote in person, but now can't because she's delivering her child. So she can request an emergency absentee ballot, fill it out when she's able, and send it into the county. The turnaround for these is tight, but it is an option that's available if you're able to request it in time and to get it back to the county by the close of polls on Election Day, 8 p.m. on November 5th. You could also request an authorized representative to assist. So regardless whether you have a disability, if you're a voter who's finding themselves in the circumstance where they need an emergency ballot, they can authorize somebody to assist with them. For instance, if they're out of town and unable to get to their polling place, they can get someone to help them out, deliver the materials. We have, again, applications available online. I would encourage anyone who is administering or in charge of facilities where they may be offering support and services to people who find themselves in you needing to check into a facility. For instance, if they're a few days before the election and maybe hadn't planned ahead and requested a mail ballot, I would encourage you to have emergency absentee ballot applications available to offer to voters who come in at the last minute and need help voting. So our main goal in talking to you today and what we've been really talking to people all around the Commonwealth about is making a plan to vote and also making a plan to assist people who have questions about or are interested in voting. Voters can check their registration status at vote.pa.gov/status. The registration deadline, voter registration deadline, is October 21st. So a few more weeks left. You have to submit your registration application by, I actually don't know if it's 5 p.m. on October 21st or like by the end of the day on October 21st. But regardless, you get it in by that date. Then they could check their status to see if the registration application has been processed. If they have a question about, they forget maybe where they're registered, what county they're registered in, where their polling place is, they could look it up on that website as well. If your voters have applied for a mail ballot, they could check their mail ballot status at that link, vote.pa.gov/mail ballot status. That'll tell them if their mail ballot application is pending, if it's been approved by the county, if the mail ballot is on its way, and if it's been accepted by the county. It's important to know and perhaps remind voters that if it's their first time voting in a polling place, for instance, if they are residing in a facility you manage, they decide to register in the location of that facility, changing their registration from their prior address. Maybe they were previously registered at another county at home, and they decide to go vote in person at the polling place near your facility. Because it's their first time voting in that location and in that precinct, they will need to have photo ID available for them. And we have information about the types of ID that are accepted on our website. And any questions about polling places, about procedures, about getting ballots in, like who's the best person to contact if you need to rush a ballot into the office, things like that. We always encourage voters to contact their counties. The counties are primarily responsible for administering and running the elections in their jurisdiction. And so your county election office is going to have a lot of good resources and staff available to answer any questions. And obviously, they're going to know more about the local towns or municipalities and facilities in their counties, so they may be able to offer more nuanced assistance. But we have lots of resources available on our website in addition to what I shared with you today, and lots of different ways you can get answers to your questions. So I know that was a lot. I tried to fit our window of time here. Um, Really happy to have Danny chime in if there's anything I forgot, but both of us can be a resource to you. We have our emails in this presentation. I know if you reach out to Diane or anyone else at DDAP, they know how to get in touch with us also if you have specific questions. But we really at the Department of State are happy to be resources to you throughout the election.
Yeah, I just point out the emergency ballot is something that is really useful. Both our governor and Senator Fetterman use them for various reasons. In the primary in 2022, it is a really wonderful option if you have somebody who's coming in who is upset that they're not going to be able to vote, who really is passionate about it. I think, you know, we would like people to we want every person who wants to vote, who is eligible to vote, so it's a really good resource. And Mike's idea of having them pre-printed is a really good idea, and if you can call your county, they can help facilitate and send a constable to come pick things up, so it doesn't have to all be on your staff. And because I know that your staff has a lot going on, and so we're not trying to add things to your plate, and we really appreciate you taking the time and the effort to help. We know that you spend a lot of time helping folks, but to help them with this, and appreciate your willingness to think about this and potentially add to your very full plates.
I also I forgot. Thank you, Danny. Absolutely, that's 100% right. I forgot to shout out to some resources, specific resources we have on we have a whole website dedicated to election guidance that offers resources for voters and sometimes county election officials on best practices. We have a couple documents up there that I know aren't maybe directly overlapped with the work you all do in the populations you serve, but they could have some good materials in them and could be sort of a one-stop shop for information about helping people to vote. We have guidance for voting for elderly and disabled individuals that lays out a lot of these procedures and options that I talked about and we talked about in this presentation. We also have a fact sheet for long-term care facilities. Again, I know that's not necessarily a direct overlap with the work you all do, but there may be some useful information in there that points you to different resources and sort of different practices to think about in terms of being ready to assist people with voting.
All right. Thanks so much, Mike and Danny. I really appreciate you joining us today. That's a lot of information that you provided to us, but it is very helpful, especially for those residential treatment providers. If there are any follow-up questions, we'll put everything together on a document, reach out to Mike and Danny to be able to provide some responses, and then we'll get that information out to the field. So thanks so much for joining today, Mike and Danny.
Thanks so much for
Okay.
having us.
All right. Right,
Bye.
so so long, thank you. All right, so if we're ready, we're going to jump into the part of the presentation in regards to DDAP updates. As we move into these updates, I just want to remind everyone that some of the information that we cover today will be regarding the ASAM criteria and the third edition. And this information is really just a snapshot of the information that you can find within the textbook. Please remember that it's a very valuable resource to have that third edition. And any questions that you may have regarding this presentation, please feel free to put them into the chat. And we will follow up after the presentation to make sure we have the answers for you, get them in writing, and then issue those out to everybody that's on the listserv. So as we begin today, we're going to begin talking about and hearing from the different bureaus at the department. So we're going to see updates provided by the Bureau of Quality Improvement, County Program Oversight, and Program Licensure. All three bureaus will be presenting some information today on some things that are happening here at the department. We're also going to provide information on the final rule of 42 CFR Part 8 and the impacts to licensing. And then we're going to help you try and understand how how the final rule and 42 CFR Part 8 is aligning with the ASAM criteria and the department's transition to the third edition that has been occurring over the past several years. So with that, we're going to start off by doing a poll question, and I'm going to have Amanda Madison from our QI side put a poll up for everyone. So if you can please take your time and submit your response. Right. So today's presenters are Jen Newell from the Bureau of Quality Assurance and Administration, Jeff Geibel, the Division Director for Division of Prevention, Treatment, and Recovery. Sue Duff is here with us as well from the Division of Program Monitoring, along with Jody Skiles, the Bureau Director for Program Licensure. And tying everything together will be Vicki Jankowski from our Quality Improvement Team. So we're going to start off today with Jen Newell, our Bureau Director for Quality Assurance and Administration. So Jen, if you're ready.
I am. Thanks, Diane. Good morning, everybody. I'm Jen Newell. I'm the Bureau Director for Quality Assurance and Administration. I just have a couple of updates for you related to one of our large funding initiatives and then some updates on federal funding. So hopefully some of you know about our student loan repayment program. We're now in our second round of that, and this round was really focused again on licensed treatment providers, but also on SCA contracted prevention, SCA contracted case management, and SCA contracted recovery support providers. In this round of loan repayment, we have about 410 individuals who across those disciplines who will be receiving the loan repayment. This time our eligibility criteria or allowable amounts were slightly different. We had 75,000 for full-time employment and 37,500 for part-time employment with a 2-year service commitment. We do have about 410, as I mentioned, people who are receiving these funds. And so we're right now in the process of sending information out to all of them to start the grant agreement process. So as you can imagine, when you receive funds from the Commonwealth, there's some strings that are attached, meaning that you have to go through the process of submitting information to us to verify employment, to verify that you still have an outstanding balance on your student loans, and then to set up some information to be able to actually execute a grant agreement. So please do keep your eyes peeled. Everybody at this point should have received communication if you are a recipient of the funds asking for the information. And at this point, we have probably 40 people who have not responded or in some cases have responded and are no longer employed in the field. But our concern is that we've sent that information out and there are some people who are not responding. So the contact information we have is what you would have put on your application. So if you or you know of anybody who applied, please do check the email address that you use, check your spam, and just make sure that if you did receive communication for us, you are responsive because we did send out a final notification. So for those individuals who don't respond back, then they will no longer be eligible for the funds and will move down to, to the next group of applicants. These applicants were prioritized based on the administration's initiative to serve rural and underserved communities. And so we were able to expand our funding to meet all of the individuals in those identified priority counties. So if some people fall off because of not responding or no longer being employed in the field, then we'll continue to move down the list on a first come first served basis. Again, based on the time that you submitted your application. There will be follow-up surveys that are going out to the first round and the second round of grantees under the Loan Repayment Initiative. And, we're just going to be tracking to see how long people are retained in the field, since obviously the goal of this initiative is to help to sustain the workforce during this time of crisis. Go to the next slide, please. You probably, if you've been in the field for a little while, you know the name SOAR. It is actually federal funding, but the name of it is State Opioid Response. We just finished the second year of um, the third SOAR grant. And what usually happens is we get a no cost extension that it takes us for an additional year. So be able to utilize any funds that were not spent or used by the programs in the first 2 years of the grant. So we did last week receive SAMHSA's approval that we can have that no cost extension through September 29th of 2025. During that time, we're just using funds on existing programs. No new programming can be held under the no cost extension period. That no cost extension period also overlaps the first year of the fourth SOAR grant. So we're now entering the 7th year of SOAR funding. And we did receive SAMHSA's approval last week as well on our application for SOAR 4. The difference between SOAR 4 and SOAR 3, or the previous SOAR grants, is really not significant, with the exception that this grant has got an initial term of 3 years instead of the way the previous ones were set up for 2 years plus a no cost extension. So the initial term of this grant is 3 years. And we are receiving Pennsylvania is receiving $83 million per year. And a lot of the initiatives that we have planned for SOAR 4 are very much similar or the same as what was held in the previous SOAR grants. And then again, our focus is on prevention, intervention, harm reduction, treatment, and recovery support services for individuals with a history of opioid use disorder, as well as a stimulant use disorder. So we try to use we take every effort to utilize the prior funding first before we switch into SOAR 4. So if you happen to be a recipient of the SOAR 3 funds or SOAR 4 funds, and you're wondering, do I start all the SOAR 4 stuff now? And is that how I enter the GIPRA? You will be notified when you should start to switch from SOAR 3 to SOAR 4. For existing programs, it'll probably be a little while yet because we want to make sure that we finish the using the funds from SOAR 3 under the no cost extension period.
Great. Lots of good information, Jen, about the funding that's coming up. So thank you, Jen, for presenting that information. So, all right. So Jeff Geibel's our director for the Division of Prevention, Treatment, and Recovery. So he's up next to talk about things that are occurring in his bureau and division. So Jeff, I'll turn it over to you.
Hi, good morning, everyone. As Diane said, I am Jeff Geibel, the chief for the Prevention, Treatment, and Recovery Division, and just wanted to give a few updates relative to the Case Management and Clinical Services Manual, which we updated and took effect in July of this year. So one of the things we put specific emphasis on was including harm reduction in the manual. And harm reduction is an intervention approach using person-centered and evidence-based public health strategies to assist people who use substances and hopefully in minimizing the negative consequences associated with their use. It's not coercive. You don't want to demand they have to do this in order to receive certain services and stuff. We want you to meet people where they are. Support each person based on what they feel they need to do and how they feel they can improve their treatment and recovery journey from there. It presents an opportunity to engage people and save lives, which there's nothing more important than that in what we are doing. The outreach should be proactive in offering people who use substances support so that they can have access to health and social services, including additional SUD prevention, treatment, and recovery services. So some examples of harm reduction is access to low barrier services, such as mobile and street outreach programs, overdose prevention, education, and distribution of overdose prevention supplies, such as opioid reversal medications and personal drug testing strips, education about health issues, HIV, STIs, viral hepatitis, distribution of safer sex kits, and FDA-approved home test kits are also examples. And also distribution of safer smoking and injection supplies so as to reduce infections and transmission of infectious diseases, such as wound care supplies, sharps disposal containers, or written materials that outline information about safer injecting and smoking practices. Please note the underline section here. This does not include sterile needles, syringes, pipes, and drug paraphernalia. That obviously is very important, and state law does not allow for that at this point in time. Okay, we also updated the Case Management Clinical Services Manual to include a section on low barrier care. And low barrier care is a model of treatment that seeks to minimize the demands placed on individuals and make services readily available and easily accessible. Aspects of the low barrier model can be seen in case management services. And the next slide will have some examples, such as utilizing multidisciplinary care teams, you're integrating screening and assessment, involving those with lived experience, so CRSs, peer services, educating primary care physicians and other providers around SUD and what happens around treatment and recovery. You want to develop collaborative care protocols, offer flexible treatment options. What can be available? What can you make available? How can you help people engage and stay in treatment? Eliminating in service engagement preconditions, that you have to do something and achieve something before you're going to get treatment services. Addressing stigma and establishing referral networks and evaluating individuals for those services. And I think that was it, Diane.
All right, great. Thanks, Jeff.
Yeah.
Again, good information on the updates to the Case Management Clinical Services Manual that were, started in July of this past year. So next we have Sue Duff, also from the Bureau of County Program Oversight, and she's going to provide some updates on her division regarding the Division of Program Monitoring. So Sue, I'll turn it over to you.
Great, thank you, Diane. Good morning, everyone. My name is Sue Duff. As Diane said, I'm the Division Chief for the Division of Program Monitoring in DDAP's Bureau of County Program Oversight. My division is comprised of the SCA Monitoring Section, which is the project officers who oversee DDAP's grant agreement with the SCAs, as well as DDAP's Compulsive and Problem Gambling Section falls under my division as well. I want to give you just a really brief update on each of these sections and then how their work impacts your work as SCAs and as provider agencies. SCAs, of course, are aware that DDAP monitors all SCAs on an annual basis. We monitor for both state and federal regulations. That federal monitoring is required by SAMHSA for all the federal clauses, all the federal pass-down language, all those requirements. The SCA monitoring section accomplishes our work through a monitoring cycle that consists of 4 phases. Throughout those 4 phases of monitoring process, we incorporate reviewing documents that the SCA submits to us. They review SCA reporting in SDS, which is our SCA data site, which is where SCAs report both contract and fiscal data. So the project officers spend time each quarter reviewing that information, and then every SCA every year has both a virtual and an on-site monitoring visit. So that's how that work is accomplished. Project officers are each assigned 11 to 12 SCAs. In order to keep some consistency, they keep those SCAs for a period of time. Obviously, we have some staff turnover. We have two of the project officers have been here about a year. The other two have been here longer, hoping everybody stays for a really long time so that we have really that consistency. But that's really what we strive for, to have that consistency in relationships with the SCAs and working together with them to make sure all of the requirements are met. Currently, we're finishing our monitoring of fiscal year 23-24. Our monitoring year runs about 5 to 6 months behind the actual fiscal year. On-site monitoring is complete for 45 of the SCAs, and project officers are currently working on reviewing the fiscal year-end reports. The monitoring year will conclude with a written report for all SCAs regarding the monitoring of all 4 phases. That also will overlap with the beginning of our monitoring for 24-25. Even though it's 4 phases, they kind of blend into one another. So as we are finishing up last year, we'll be starting the monitoring for 24-25 with first quarter fiscal reporting and entry of provider contracts for 24-25 will be coming up later this fall. So I know, and thank you, Diane, that's the next slide. That's good. I know that many of you on the call do not work for SCAs. You might work for provider agencies. So I wanted to kind of just give you some information about how the monitoring process really impacts you as well as provider agencies. As I mentioned, the SCAs do complete fiscal reporting in our SDS system. That is done on a quarterly basis, and the SCAs have to have timely invoices from providers in order to be able to meet our timeframes for quarterly fiscal reporting. So that's one way that you as provider agencies can be really helpful in making sure, if your clinical staff, that your documentation is done, that invoicing is done from the SCA from the provider to the SCA, so that the SCA can then meet timeframes required for fiscal reporting. SCAs, again, are required to also keep their contract information updated in SDS. So if you're at a provider agency and you're involved in the contract process between you and the SCA, kind of keeping that moving and making sure contracts are clear and accurate and timely is very helpful for the SCA side and for our monitoring. We do have specific requirements for SCAs to set inpatient and outpatient rates and how they do that. And so that certainly impacts you as provider agencies, that you have to work with your SCAs in order to do that. Many of you probably are aware that the SCAs are required to monitor all of the contracted providers in their counties. If you're contracted with multiple SCAs, you are only monitored by the home SCA. That's how our system is set up. That monitoring is also required from our federal funding sources. Those pass-through requirements require that the SCAs also monitor the providers. And then finally, when our program monitoring staff go on site to the SCA for the monitoring visit, we do review some of the invoices that are submitted by providers. And so some of you may know that you've been required to submit case notes for a certain number of clients for a certain period of time to your SCA. And that's just because we do that invoice review. Just as the SCAs do invoice reviews at your provider agency, we then do that for the SCA to make sure that they're following up on any kind of payment issues. So those are some of the ways that our monitoring impacts you as provider agencies as well, even if you're not working for an SCA. And then the last slide, I want to also just make sure that we continue to include gambling in discussions around client needs. DDAP receives funding from gaming revenues across the state, and then our compulsive and problem gambling program uses these funds to take a multi-dimensional approach to tackle problem gambling. We do contract directly with treatment providers to pay for problem gambling treatment for those without insurance. Some of you might be from agencies that have those contracts and that provide treatment for gambling. If you don't currently, but it's something you're interested in, certainly get in touch. I can connect you with the team who does that. But all of you who do level of care assessments for substance use disorder clients, probably know that there's a couple questions on that assessment that have to do with problem gambling. That is because we want to make sure that if people have that issue in addition to their substance use issues, that they're getting connected with treatment. So anybody identified as possibly having a gambling problem should be referred to the 1-800-GAMBLER number that's on your screen. That's how the staff that handle those phone calls, and they also can do texts. They get them connected to our DDAP contracted treatment providers. On the prevention side, prevention for problem gambling is done through the SCAs. We are looking to expand that in the coming years. Those services are funded by DDAP, and those will be required of all SCAs starting next year. And then just to give you some idea of some new initiatives, some new programs that we're looking at, we are adding case management services for clients with problem gambling. This has already been approved. We're in the process of adding a staff person and writing all the requirements for that program, and that will also be done through contracts directly with case management providers. That information will be forthcoming later this year, probably into 2020, the beginning of 2025. Training in problem gambling case management will be required, and that training is also being developed right now. So we are going to be definitely adding that. We're also looking at creating additional prevention training so that prevention staff feel more equipped to provide prevention programs. We're also possibly looking at creating a statewide prevention program for problem gambling. And then some more kind of far-reaching goals. We're looking at exploring residential treatment options to include inpatient treatment and then halfway or recovery housing for problem gambling clients as well. So again, a little bit off topic, but certainly an issue, that we feel is important to continue to include in your discussions and make sure that you know how to get people connected to treatment. So thank you very much, and feel free to reach out if you have any questions.
Wow, great information, Sue, and thanks so much for that update and even the long-term goals of the department around the gambling side. So appreciate all that information you were able to give today.
Yep.
All right, so next up, we have our Bureau Director of Program Licensure, Jody Skiles. She's joining us today, and she's going to talk on a few topics, but focus also on the final rule of 42 CFR Part 8, which impacts our opioid treatment providers. So Jody, I'll turn it over to you.
Thanks, Diane. So good morning, everyone. I'm going to just talk about a couple of initiatives that are happening, and primarily, like Diane said, we're going to spend a lot of time, or probably not a whole lot of time, we've got about 15 minutes left on the final rule. The first one I wanted to talk a little bit about I'm going to talk about the mobile medication units. Licensing alert was issued in 2022 explaining the process of a mobile medication unit. Those units can do everything that bricks and mortar OTP can do. We currently have 2 licensed in the state of Pennsylvania, so hooray for that. The first one was Gadendia in Cole Township, and the second one, which we received notification last week on Wednesday afternoon, is Marikey in Philadelphia. So that one will hopefully help in Kensington area. That's what they were looking forward to, that mobile unit doing. So that, again, can do everything that bricks and mortar unit can do. The mobile unit can help in rural areas with transportation issues. It truly meets individuals where they are. There are also several others in process throughout Pennsylvania. So you will see this popping up throughout the year. Next slide, please. Central registry. This is something new. There are several states that have these throughout the United States. We are going to get one, hopefully probably not this year, but next year. What a central registry is, it is one system where all individuals that are involved in opioid treatment will have, it'll be one unit that directly communicates with an EMR. It will help our providers. Those of you that work in an OTP know that you are currently signing consents, and I'm glad people are happy about this. You're currently signing consents, and you have to fax that away to those surrounding OTPs and wait an hour or two, and hopefully they'll keep that. Yes or no, somebody is involved. What a central registry does is within seconds, you will know that they are or are not involved in an OTP. This can also communicate with individuals via text alerts or email if an emergency happens due to a facility closure. It will also communicate. We're getting a function that it can coordinate with the PDNP with individual consent. An individual has to consent to allow that to occur. So this is something that's upcoming. Again, it's not going to create additional work for our providers. It will help you. So the data will be extracted from your EMR into the central registry. When we did a survey, one of the concerns was, will we have to do dual entry? No, you will not have to do dual entry. Next slide, please. Okay, so here's the big topic, 42 CFR Part 8. So what I'm going to talk about today is Pennsylvania's response to the updated federal regulations. This is a huge change. SAMHSA has staffed themselves with people that provided direct services, which really made these new updated federal regs just good for us, good for the field. That's all I can say. They're very clinically driven. They're about meeting individuals where they are. It's about you as a clinician. It's about physicians making decisions. It is about good individual care. So I wanted to say that up front. It is about just meeting people where they are. And I'm going to say that a lot throughout this presentation. So we issued a licensing alert last week that we are going to provide exceptions to parts of our 715 regulations. And I'm also going to say that we are currently in the midst of reg reform. So many of our 715 regs are going to change. Next slide, please. Okay, the first one, under intake. We are going to allow adolescents or anyone under the age of 18 to seek medication for opioid use disorder. As you know, individuals under the age of 18, if they can cognitively sign a consent, if they can cognitively walk into a treatment program and say, I want help, they can, in Pennsylvania, get treatment. They can now access MOUD in all forms in Pennsylvania without parental consent. You don't have to reach out to DDAP to ask us, can I put this individual on Vivitrol? Can I put this individual on buprenorphine? Can I put this individual, this 16-year-old, on methadone? We now have an exception for that. That allows you. And next slide, please. We've provided an exception to 715.9A. An OTP no longer has to verify that an individual has an OUD for 1 year. This one, I think, is going to save a ton of lives. This is not your heroin of the 70s. And I say this all the time. This is pure heroin. It is laced with all kinds of other pure drugs, and it's killing people. So someone becomes addicted right away. So having an OUD for 1 year is, and many of you know me, and I'm just going to say it like it is, it's pure insanity to have to require that somebody is addicted for 1 year before you can put them on methadone or allow them to seek methadone. So this is going to save lives. We've agreed with 42 CFR, and we're providing an exception to the 1 year. Okay, so next slide, please. 715.12, informed patient consent. Now, this is not going to affect us too much right now. However, you've met some of our partners at Department of State when we started this webinar off. Longer term, there's going to be telehealth allowed, audio visual for physicians to work with patients or individuals in services. And we are going to allow verbal consent for treatment. And we're going to allow this exception is out here for when that occurs. So for those of you that do not know, the Department of State has, and we'll go through this a little bit later, but there's a IRC hearing November 21st, I believe, regarding the prescribing of medications for opioid use disorder, going in front of IRC by physicians being able to use telehealth. So we are very excited about that. They got an expedited hearing, so this will come more into play at that point to get verbal consent when it's audio visual. So next slide, please. 28 PA Code 715.14. So here's another change. Currently, we require 12 urine drug screens. And it specifically says urine drug screens to be done randomly, 12 of them, and they have to be urine. So we've aligned with 42 CFR Part 8, 12 F6 to allow providers to capture 8, and they can be now done by oral swab or urine. And I think that this is rather important. One, because of trauma, individuals, even being in active opioid use is traumatic. I don't know how difficult I can't tell you how difficult it is, but it's traumatic for people to just maintain that lifestyle. So coming in and having to pee in front of people could be hard for people. So allowing that oral swab is going to be helpful, I think, for some. So you no longer have to request an exception to use oral swabs. They need to be done 8 times randomly throughout the year. You can do more, not less. Next slide, please. I took many more notes on that one, but well, we'll forego them for time.
Jody, if you'd like to go into more detail, I think that's fine. I think what we're going to do is present the changes to present the final rule to 42 CFR Part 8, and then hold the discussion regarding ASAM to November and how it impacts and ties in. So feel free to just finish out your final rule, and then we'll use a session completely for the ASAM piece of it.
Okay. Then I can get on my soapbox a little bit.
If you would like to, absolutely. As you said, the providers know you, so I'm sure they're expecting a piece of it.
Just a little bit. Okay, here we go. Watch out. Here's a good one. Okay, so this is this one is 28 PA Code 715.15. This one discusses the dose that a provider starts with. It's been 30 milligrams for how many years? Forever, right? Now, SAMHSA has it at 50 milligrams However, this is clinical judgment. Clinical judgment is very, very interesting to say, because I think that, and SAMHSA has said this in some of our SOTA meetings. And SOTA means State Opioid Treatment Authority, for those of you that don't know the acronym. But they have stated our providers are having a difficult time using their clinical judgment because regulations have told them what to do for so long that they're having a difficult time determining what to do clinically. So we are allowing you to make clinical determinations about what an individual needs when they walk in the door. So looking at a person when they're coming in, prescribing what they need based on their individual needs and where they are. Again, reminding you as a director, as a physician, as a CRNP, a PA, we added the Medical Practice Act here to not go beyond your individual scope. So initial dose must be determined currently by a physician. The initial dose. Other ongoing doses may be determined by a PA, CRNP within the scope of practice. Take homes can be allowed, the decisions can be made by the CRNP PA within the scope of practice. We've had you've always had to submit those requests for the exemptions through SAMHSA, through the extranet. So read what the scope of practice, within your scope of practice, you must continue those. But again, we're working with Department of State to allow the telehealth and to allow the physicians to do audiovisual with methadone. I'm probably talking in a big circle. Reminds me of our friend, you know who, Diane's laughing. But doses, initial physician, the rest can be done by the extenders. Does that make sense? Or did I confuse everyone? No? Yes? Okay. Next slide, because we're hitting 11 and I've got an 11 o'clock. Take-home medications, we've been doing these through COVID, so I'm not going to get into this other than individualize. I put this in the chat. Individualize where people are. You know, we don't want to continue with that old 6-13 forever. They can have up to 28 days of take-home medication. You wouldn't want to be tied to going somewhere every week just because you always had to do it. Make sure you meet people where they are. Next slide, please. This one is really where I wanted to be on a soapbox, but somebody had other plans. So we've been receiving requests to increase caseloads to 70-1. Because to align with the federal rule of no counseling. That is not what this says. This says mutually agreed upon counseling. You must provide counseling. What we are saying is that it's no more minimum 2.5 hours. You still have to provide counseling. Just think about if you have the flu. And that's what opioid withdrawal feels like. It's a flu. It's like a flu. You're sick. You wouldn't want to be sharing your deepest, darkest secrets with people. Work with people. Document they're sick. I'll meet with them next week. Think about where people are when they're coming in and start to work with them. And as Diane said, we'll go into this much more in depth next month. Next slide, please. And then finally, withdrawal management, there's no minimum. Work with people, no 180-day limit. You can take 10 years if you want. Work with people individually. If they want to come off in a year, slowly work with them.
All right. So thank you, Jody. So what Jody's gone over today are really those the update to the final rule 42 CFR Part 8. And part of next month's presentation in November is we are going to talk about how this final rule is really does align with the ASAM criteria and individualized person-centered treatment. So we have our slides all ready to go for that November presentation. I really do appreciate everyone who was able to get on to the call today and hear the DDAP updates across our different bureaus and also hear from Department of State. Very important election information on voting for our residential treatment providers. I want to thank Mike McDonald and Danny Bendeski along with Jen Newell, Jody Skiles, Jeff Geibel, and Sue Duff for presenting information today. And as I said, we will do a presentation next month around the final rule and how the changes align with the ASAM criteria. And that piece will be done by Vicki Jankowski from our quality improvement team and other members of the team. So thanks so much, everybody, for participating today. Any questions that are into the chat, we will be responding to them and we'll put out a document with the responses. So I hope everybody has a great day and thanks for staying on for a couple extra minutes. Bye-bye.